So next is infra inguinal occlusive disease. How would you manage a 60-year-old gentleman with a non-healing ulcer at the fifth metatarsal for 3 months at the clinic? He is a heavy smoker and claudicates 100 yards and works as a security guard. So first of all, I will take the history, specifically about the claudication, distance, any rest pain, any tissue loss, and then I will ask about the risk factors, hypertension, diabetes mellitus, renal failure, and hypercholesterolemia, family history of ischemic heart disease, and smoking, and alcoholic drinks, and then I will ask about medications, allergies. Then I will do foot X-ray, wound swab, involve podiatrist and arterial duplex scan, and do ABPIs. Arterial duplex scan shows 10 cm of the mid SFA occlusion. While would you list the patient for angioplasty or above knee fem-pop bypass? What's the evidence? So there is no evidence not supporting either technique. If patient is fit, he should go for fem-pop bypass. If patient has medical condition, then he should have angioplasty first. How do you initially investigate 70-year-old man referred to you from medical team with rest pain and dry urine of fifth git hallux? Again, he needs open analgesia, blood test, FBC, UNE, CRP, clotting, X-ray of the foot, and duplex ultrasound on the left lower arteries. Duplex ultrasound demonstrates 25 centimeter long occlusion of the left SFA with runoff via posterior tibial and peroneal artery. Discuss results options. So again, endovascular angioplasty plus minus stenting, and open surgery, fem-pop or distal bypass, preferably with vein conduit. During angiography, it was not possible to cross the SFA occlusion successfully. Vein mapping reveals no visible gene of his lower limb. What are your surgical options now? Now we have to look for venous conduit from the upper limb. Splicing of cephalic or basilic vein segment may be needed. If there is insufficient vein, then prosthetic bypass graft can be used. The segment of a vein harvest to form either a Miller cuff or St. Maurice boot, and perform remote endoarterectomy. The fem-pop distal bypass performed was complicated by a groin wound, lymphocyte, and secondary infection by MRSA. Pus is now discharging from the groin wound. What are your surgical options now? So we have to justify first, assess whether this is a graft infected or the soft tissue around the graft is infected. If graft itself has become infected, then it is likely that the CFA anastomosis will eventually give way, leading to catastrophic bleeding. But if it's superficial tissue infected, then it's debridement and negative suction dressing. And if patient is fit enough for second surgery, then we can do extra anatomic bypass such as via obturator canal or lateral around the groin. Depending on the initial target vessel, was the posterior tibial peroneal artery, it may not be possible to just close the same vessel or use the same approach of the vessel. And if we are doing revascularization, then we will need a sartorius flap. If not, then patient will need amputation. Thank you.